evening, everybody, and welcome all of you to the 91st live program on orthopedic principles. Today, our guest honor is Dr. Ali Noorani from the United Kingdom. Dr. Noorani has qualified from the Imperial College School of Medicine in 2000, and Mr. Noorani completed his orthopedic and trauma training on the prestigious Royal London Hospital rotation together with 16 months training at the Royal National Hospital at Stanmore. He undertook further specialist fellowship training in shoulder, elbow, and upper limb surgery at the global renowned upper limb fellowship program at the Royal Liverpool Hospital. He became the fellow of the Royal College of Surgeons in 2009. He's also a shoulder surgeon at the London Institute for Sports Exercise and Health, UK's only International Olympic Committee recognized center. He's a medical director of Global Strategy for Orthopedic Specialists, president and director of Global Strategy for the Harley Street Specialist Hospital, and co-founder of the Regenerative Clinic. So today, it's my great honor to introduce you to Mr. Ali Noorani from London, United Kingdom. Over to you, Ali.
Thank you so much for the kind introduction, and it's a real honor to be presenting on this forum. So thank you once again for the invitation. Today, as most of you probably know, that I am an orthopedic surgeon. I specialize in shoulders and elbows. I work on the NHS at Bard's Health, which is part of the Royal London Hospital, which is Europe's biggest trauma center currently. But I do have some other hats on, including being the medical director of a group of orthopedic surgeons in London called Orthopedic Harley Street Specialist Hospital. Today, we're going to talk about something relatively straightforward in the shoulder world. In oriphysio, you would see lots of people with this, i.e. ACJ instability. So without further ado, I will proceed. So what are we going to talk about today? Well, we're going to talk about the basics first. So we're going to talk about AC joint anatomy and what keeps the joint stable for ACJ instability and my personal thoughts on that classification. Then for those of you who are more surgically oriented, and we'll touch base upon the management of chronic injuries as well, which is often slightly different in these cases. And finally, a little bit on techniques for fixations, what is out there, and what my current preferences is and why. So let's talk about the joint stability. So AC joint, like any other joint, is kept in place by various factors. As we know, there are static factors as well as dynamic things that control any joint. Okay? Now, for a glenohumeral joint, for example, we know that dynamic factors like the rotator cuff play a massive part in it. Whereas, for example, a different joint like a hip joint, we know that static factors play a much more significant role. For every joint relies on ligaments, bony congruency, as well as muscles around it to control it, in addition to a good functioning neurological system. So what are these static things that we deal with in the AC joint? So this is a picture of the clavicle going into the ACJ, i.e. a snapshot of the shoulder girdle, the bony anatomy with the ligaments. Where you see that circle is what we would call the AC ligaments, and including the joint capsule. Just below that, you have the CA ligaments. The main ligaments that provide stability to the AC joint, which is circled, is actually slightly away from the joint, i.e. the crococlavicular ligaments, which have two parts, the trapezoid and the more important part, the conoid part. These are very, very important ligaments that are involved in the stability of the ligaments. And although they are static points, you can see that they fan out and they have a different direction of attachments. So they end up providing a good three-dimensional stability to it. So as far as AC joint is concerned, the ligaments provide a significant amount of stability to it. But let's not forget the bony anatomy. The bony anatomy is also quite important. So the AC joint itself has some congruence. And we know that when you lose the end of the clavicle, you get a lot more anterior and posterior draw, i.e. anterior posterior instability. So here we are talking about the bony anatomy, right? In addition to all the other ligaments that are there as well, just a different way of looking at it. Now, I just want to show you all the different muscles that are attached to it. We often forget how large the muscles are that attach around the clavicle and the acromion to stabilize the shoulder girdle, as well as provide significant stability to the AC joint. So trapezius, deltoid, big massive muscles, and which provide so much of the stability around the AC joint. So people often forget when they're treating and managing AC joint instability that the muscles play a large factor in this. This is a good slide. I often use this for my teaching. It talks about the age and what diagnosis you expect. So if I'm a shoulder guy, if I'm teaching trainees and so on, I often put this slide up, even to medical students. In fact, my son, when he was 5 years old, could use this simple algorithm and figure out what the most likely cause is when a patient presents to you. So age is so important. We know that as you get older, you tend to get arthritis, including arthritis of the ACJ, full thickness cuff tear. And there's a whole middle-age group where you may get ACJ pain. But if you're talking about the younger age group, that's where you see trauma. That's where you see injuries. So we tend to see a lot of ACJ dislocations in the 30-odd-year-old. Now, I live in London. There are a lot of people that want to do cycle more and more. It's great for fitness. But London is not designed for cyclists yet. So it's a very dangerous place to cycle. So a significant number of my patients that on the NHS and private are actually cyclists that fall over. And when they fall over and they hurt themselves, they often tend to break their collarbone or dislocate their ACJ. And this is what it looks like. So on the right-hand side of the patient is what a typical bump that you would get from an ACJ dislocation. And on the left-hand side, you can see that there is some clear asymmetry between the two sides. So we know that there is a significant prevalence for this injury, right? So it is graded according to 1 and 6, but the unstable type 3 and above is actually relatively common, or approximately 15 out of 100,000 per year. And the incidence obviously depends on activity, right? So if you're a rugby player, you will have a big chance of dislocating your ACJ, but you can get lots of traumatic shoulder injuries in cycling and other pathologies. So although I see a lot of rugby players because I treat professional athletes, because cycling is done so often that even though smaller number of patients hurt themselves from cycling, I end up seeing a larger number just because there is a lot more cyclists out there. Just remember that there are lots of other intra-articular pathologies that can be associated with ACJ. An ACJ dislocation is a very high energy injury, and somebody has enough force to dislocate an ACJ in a young person. You have to think to make sure that nothing else is injured. So just because there's an obvious injury on physical examination by inspection and x-rays, please don't forget to make sure you examine the rest of the shoulder, because there is more than 15% chance that there will be another significant injury to the shoulder, including a cuff tear or labral injury, which may need to be addressed. So here's a picture of typical person in rugby falling over on the tip of the shoulder, dislocating the ACJ. And similarly, when cyclists fall over, especially the good cyclists, they tend to hold on to the handlebars for as long as they need to, and then when they fall on the tip of the shoulders. So what about the classification? I personally am not a fan of the classification, and I will give you my thoughts on it later. But the Rockwood classification is the one that has been used. It's a classification based on X-rays, because again, it's a very traditional classification, which is many, many decades old. So we only had X-rays. And what the classification would show that on type 1, the X-ray would look normal. But if you had the opportunity to assess, or now in modern times, you do an MRI, you might see a sprain of the AC joint itself. Very stable injury, not really a problem. Type 2 is when you actually disrupt the AC joint ligament. And in most cases, this is also a very stable injury, and the main CC ligaments are still intact. Most patients do not require any surgical intervention, and in some cases you require rest, non-steroidals, and then rehabilitation. So what about type 4? We're skipping type 3 for a second. There's the type 4 where it apparently just goes posteriorly. Goes superiorly. Type 6, but apparently only one of my colleagues has ever seen, and if any of you have ever seen it, please let me know, because that's when the clavicle goes underneath the coracoid. It's so rare that I haven't seen it, and I see this as one of the most commonest injuries. So type 1 to 5 is what we would normally see, okay? Is classified on the original classification by Rockwood, that is between 25 and 100% displacement. It is likely that the CC ligaments are gone, but the displacement isn't enough to justify fixing, or is a gray area. So there is some confusion. What do we do with somebody with type 3 that has got a dislocation? Clear. 4, yes, it's clear. We probably operate as well. 1 and 2. So very basically, if you have a type 1 and 2, we do nothing but to address the pain of the ACJ, maybe something that we need to consider later on. When it comes to 4s and 5s, because they're very likely to be unstable injuries. 6 is rare, but of course we'll fix it. So what about 3s? And the way I want you to consider this is actually not a constant classification, because the classification can be very, very misleading. There are certain injuries that look like type 1s and type 2s that may be a significant injury when you assess them. And certainly there will be type 3s that actually are type 4s and 5s, but are only apparent when you examine them. So the way to start thinking ACJ injuries is to simply decide whether this is a stable injury or an unstable injury. And we know that in most cases, type 1s and 2s on an X-ray tend to be stable. Type 4s and 5s tend to be unstable. And the ones that are kind of in the middle just need to assess whether there is instability or not. So I put it to you that X-rays are not a good way of classifying and then treating a patient. There will be some 5s that you know that are very likely to be unstable. But if you just treat the X-rays, you will miss out a lot of ones that look like 1, 2s, and 3, which are actually a much worse injury, but has not been recognized as such. So, what are the surgical considerations for these different types of injuries, right? So type 3 injuries. Well, there are 2 different approaches, right? We do see some patients that have had an acute injury right? And the ones that we need to fix are the ones would be high level athletes, people who have, you know, manual workers and so on that may want to, you know, get back into their work and require a shoulder girdle to be very, very stable. But let's not forget the fact that there are a significant number of people out there that don't mind the cosmetic deformity and will do really, really well without any surgical intervention. So imagine a 50 to 60-year-old, not very active, sedentary lifestyle, dislocated the ACJ. You just have to consider what the future functional deficit will be and maybe justify not fixing that acutely. If you, on the other hand, have a high-level athlete or a weekend warrior that cycles every day, goes to the gym, does a lot of overhead sports and overhead weightlifting, then they need a more stable shoulder, and therefore an ACJ fixation acutely is a good idea. So here's an X-ray of what a typical grade 5 would look like. It's pretty obvious. You can see the clavicle going all the way up here. It should be down by the acromion, and this has gone through. Now you can imagine, although this is just an X-ray, you can imagine that the CC ligaments would have been gone, which go between the coracoid and the clavicle. You know for sure that with this kind of disruption, the AC ligaments are gone, and it's very likely that the whole deltotrapezial fascia sitting around it would have been torn as well. Straightforward, grade 5, no problems, right? We are all happy with that. Well, what about this one, right? An X-ray seen in clinic, and you wouldn't think about it twice. But when the history suggests that somebody has AC joint pain, when somebody's fallen on it, you can start looking at it a little bit closer. It's a static X-ray, but we can see that the alignment of the bottom of the clavicle and the ACJ, or the acromion, is actually slightly different. The clavicle is relatively slightly higher than the other side. This may be a normal finding, but in this case, it was symptomatic. He had pain there. He actually had a lot more instability than what the X-ray suggests. Because don't forget that a lot of times when patients are injured, they will hold their arm in a sling, and the arm will automatically reduce the disruption to a much better level. So dynamic assessment of instability is quite important. So here would be what's somewhere between grade 2 and 3. Now, I believe the classification is flawed. We cannot think of ACJ disruption as a linear deformity. It can't just go up or backwards. We know it's not true. Nothing else does that. It is a 3-dimensional rotational deformity, okay? We also know that the X-rays can show dynamic improvement. And this is what I was alluding to earlier. If you reduce your shoulder in such a way that you pull your arm elbow up, you can push your shoulder and reduce the ACJ. Similarly, if you put traction on your arm, you can exaggerate and make the deformity worse. So X-rays are not reliable, clinical examination is. Now what about 4 and 5? We know that 6 is very rare and is a different beast and probably rarely exists. But 4 and 5 actually are the same thing, right? It's very rare for a clavicle to go backwards or very rare for a clavicle to go upwards, right? So 5 is upwards, 4 is backwards. What really actually happens in real life is it goes upwards, backwards, and rotates because you have lost the ligaments. And we see this more often than the individual 4 or 5, because if you do assessments and X-rays on these patients, you will see that on the strip axial or axillary, the same clavicle is going backwards and the same clavicle is going upwards, i.e. there is no distinction between 4 and 5. So examination becomes really important for decision making, and then the X-ray. And again, going back to the same thing that I may repeat myself, which is a really important take-home message is look at the classification, document it, but then ignore it. Think about whether this is a stable injury, where the clavicle is wobbling around, or whether this is a very stable injury and doesn't need fixing. So unstable things require an intervention, like surgical intervention, and the stable ones perhaps don't. So the next thing is that we often think of this as a clavicle injury. Doc, the clavicle has gone up. Well, that is also not true, okay? So if you think of it as a clavicle has gone up, you may think of this as a fairly minor injury. But in actual reality is, anatomically, from a description point of view, as well as actually what happens from it, the clavicle stays where it is, and is actually the whole of the shoulder girdle falls away. You got to remember that the clavicle is the only bone that connects the body to the arm. Everything else is muscles and ligaments and so on. So one bony structure connecting the whole of the arm. And when you dislocate your clavicle, if it's an unstable arm injury, the arm falls away. It can be classified as a thick scapular syndrome, where there is scapular malposition due to the disruption of the ACJ, or the scapula protracts, wings slightly because the inferior pole of the scapula becomes prominent. You may get some coracoid pain and impingement, again because of scapular malposition, and you get lots of dyskinesia of the scapula because you lose that stable base. So this is a real thing, and this is something that we need to be aware of when we're treating these clavicle injuries, ACJ injuries. So here's a 3D reconstruction of a typical patient. On the left-hand side, i.e. right of the screen, is a joint, AC joint in the normal position, okay? So both views, one from the front, one slightly looking from above, you can see exactly what the position is. But if you look at the right-hand side of the patient, i.e. left of the screen, you will notice what exactly I'm talking about. You notice three things. Firstly, on the picture above, the AC joint has gone up, i.e. what will typically be looked on an X-ray as a grade 5. What you see on the bottom picture is something that looks like a grade 4. But if you play close attention, what has actually happened and is that if you look at just the clavicles, the left and the right one are exactly in the same position. What has actually happened is the right shoulder girdle has fallen away, rotated away. So this is what happens in an ACJ. And once you start thinking like that, you recognize that a clavicle dislocation, ACJ dislocation, is actually a shoulder girdle dislocation and a much more significant injury than people may think. So here's another example. This patient of mine had, was actually one of the staff members. He's had about 9, 10 surgeries under 4 or 5 different surgeons. He's had everything done. He had everything to make it stable. He's had, Weaver done, he's had a hook plate, he's had grafts, allografts, synthetic grafts. He still has some synthetic grafts in. His position looks okay on X-ray. We can see there's a little bit of a gap, but maybe it is slightly high. And if you look at the axillary view, we can see that, again, maybe slightly backwards. It didn't look too bad, but he had a lot of pain. If you look at his pain, where was his pain? His pain was basically neck, trapezius. He was getting traction from his plexus because...
Ali,
yes.
Your hand is on the speaker.
So how is that now?
Yeah, that's better.
Apologies. So we can look at it, and what we saw was that he was getting trapezius pain. He was getting a traction of his brachial plexus because the shoulder girdle was in the wrong position. So he's getting numbness and pain in the T1 distribution. So clearly he had a classic thing of 6 scapula despite the surgeries. So this is again looking at the same person, 3Ds. You know, we can do all sorts of imaging on it so we can see what it looks like on the outside. And I'm just going to rotate this around and just want to demonstrate. It's the same person, and just look at it, right? If you look at it from the side, you can see that although the linear alignment may look okay, the scapula is completely rotated outwards. And this gentleman essentially required me to recognize this, and this was apparent clinically as well, by the way. So I got this CT as a demonstration for the teaching purposes, also to plan his surgery because he had so many other bony work done. But it's a good demonstration to show that when you saw this guy clinically, you would see that his scapula is so malpositioned. And if you reduce the rotational deformity, you actually will correct the symptoms. So another guy, you know, again, just to demonstrate something that looks like a typical grade 3 on the AP, but looks like a grade 4. Often a combined thing because the grading for Rockwood is probably not right. This is again a very unstable injury who has gone upwards, backwards, and rotated. Similar guy, right? You'll see his imaging here. He's under anesthesia right now. You see that little bump there. And I'm going to see if this video plays as well. And hopefully you can hear the sound as well.
4/5 ACJ dislocation.
So grade 4/5/ACJ disruption.
The clavicle comes down here, and this is the end of the clavicle.
That's the end of the clavicle
this is
there.
right in the subcutaneous tissue.
Just under the skin.
This is meant to be down here somewhere.
Yeah.
So it's obviously gone.
So I'm just pointing out where the clavicle is supposed to be anteriorly and how it's poking backwards. So even on visual inspection, we can see this clavicle has gone backwards like a grade 4 and superiorly like a grade 5. Again, a 3-dimensional rotational deformity. Very, very unstable on palpation.
These are highly functional.
Another picture. Now this you would see as looking normal, right? That's a pretty normal looking X-ray on the first glance. There is no evidence that has gone upwards or backwards on any of these X-rays. But this guy came to me as a tertiary referral with a lot of ACJ pain and symptoms suggestive of ACJ instability. If you look at his X-rays, on the right-hand side, that is normal X-rays. On the left is the abnormal X-rays. And once again, what I've purposely done is put the shoulder girdle in the normal position, and I'm just demonstrating the position of the clavicle. If you look at the clavicle on the right-hand side of the patient, i.e. left of the screen, you will see how nice and square it looks with a good alignment. On this other side, you see that although the alignment is good, it is actually rotated by about 40-45 degrees. So again, symptomatic instability, rotational deformity, although the alignment looked good. And when I did an EUA on him, so this is an MRI scan, again shows complete destruction of the AC ligaments, CC ligaments strained but not torn, but still having symptomatic instability. And I am now going to do a little demonstration in theater. He's asleep. And what I can do is literally move his shoulder girdle backwards and forward. Very, very unstable. And again, a very grateful customer once we stabilize the ACJ. So the take-home message we're saying is that examination to confirm the ACJ instability is very important. I'll just repeat that again so you can really see how I move the shoulder girdle back and forth.
There's quite a bit of movement in the anterior posterior.
And what a minimum pressure requires just to push the clavicle back and forth.
Superior infuse direction as well.
So my take on management is grays does not matter that much. Do not rely on X-rays or even 3D CTs. Always examine the patient in the clinic because that'll give you almost all the information you need. And X-rays and MRI scans, they're the icing on the cake to then further manage. There's also no immediate rush. Most of the acute injuries can be easily fixed within the first 6 weeks and have a great outcome. And the chronic stages, if you do them, and I'll show you the difference in how I treat them, waiting can still give you good results. So if I have a patient that has an acute or chronic ACJ, within 6 weeks, I would treat this as an acute injury. We often think that the CC ligaments tear in intra-substance, but usually they strip off as a periosteal sleeve from the underside of the clavicle. So you don't need to augment with any kind of grafts, whether synthetic, allografts, or autografts. In the early phases, if you just reduce it and provide three-dimensional stability to the construct, then the ligaments and the stripped off with the periosteal sleeve heal quite nicely. So I will use a dog bone from Arthrex, or even go really old school and use a hook plate, which is really, really robust. The only problem being that you need to remove it. But these are just tools to provide stability so that these CC ligaments can heal. I will do a repair of the AC ligaments and the capsule, especially the posterior capsule that provides a lot of proprioception. And I'll do a formal repair of the muscle. But as far as implants is concerned, anything that provides stability is good. Once you reach the chronic stage, it's a different matter. Suddenly you're thinking that it may not heal, and any kind of implant may fail if the ligaments are not there to support it in the long term. So I still might use a dog bone and a hook plate, but I will probably put a graft, whether it's synthetic like a lockdown ligament or a allograft or autograft. I don't tend to use too many autografts, but allografts and synthetics are my go-to. So when you think about surgical treatment for acute injuries, address all the stabilizers of the joint. That's important. So there is a periosteal sleeve avulsion of the CC ligaments. We need to reduce the clavicle and hold it stable, and those ligaments usually take care of themselves. Repair the posterior capsule of the joint and the AC ligaments because it's right in front of you. The posterior capsule provides a lot of stability and proprioception, very important. This is not controversial as I'm concerned. Lots of people have shown this, including Musaka in anatomical studies. Please do not resect the lateral end of the clavicle. Lots of people will have guidelines and op-texts that say resect the end of the clavicle because it may get arthritis. Arthritis of the ACJ is part of life. People get gray hair and wrinkles. They'll get ACJ arthritis as they get old. It doesn't hurt, and it only hurts when it's unstable. So usually people don't get arthritis, and if they do get arthritis eventually, like they normally do, it doesn't hurt. And take it from me and take it from the literature, having treated thousands of these patients, removing the lateral end of the clavicle is not beneficial because people don't tend to get ACJ pain. I've had 1 or 2 patients out of literally thousands I've done, and they respond well to 1 or 2 injections. That's it. Never had to resect an ACJ. But resecting the ACJ acutely can result in a lot of anterior-posterior instability. And we know that bony anatomy is important for stability, along with the ligaments and the muscles. So please don't remove it. You can remove the intra-articular disc, which is occasionally not present if the patient is older, but if it is, can be ruptured. So remove that because it can be neurogenic and a source of pain, but preserve everything else. Now, I spend a lot of time and effort repairing the deltoid and trapezial damage, as well as doing a formal Mason-Allen repair of the deltoid trapezial fascia to wrap around the clavicle construct. So when you've done your fancy treatment of dog bones and so on, don't walk away quickly and let your juniors just close up the muscle right on top. No, do a proper formal repair of the muscles because that is very, very important for stability. So, for chronic injuries, same, but just I need to augment with some kind of ligaments. And, I tend to go for synthetic ligaments in this case. So my take is patient factor is always important. Work demand, even cosmetic is important. Athletes fix them. Consider other symptoms from the shoulder girdle. The concept of sixth scapula is important. And people do get plexus traction, pain, scapular dyskinesia, right? But there is no immediate rush. You can wait and do these delayed as well if the decision making is not clear. And again, acute, I tend to see them early. I tend to see most of them for rehab. Unless there are athletes and so on, I would make a decision to go ahead at 3 to 4 weeks. Of course, if it is tenting the skin and grossly unstable, I will fix it quickly. Chronic, definitely rehab them all, because you've already lost the chance of doing an acute injury, and you can wait for as long as you want. So if somebody's having problems around the shoulder girdle, there's nothing to lose by doing rehab. And this prehab works wonders if you end up doing surgery in the end. But a significant number of them that have symptoms in chronic instability where you've not had the chance to fix it acutely, rehab by itself can avoid them surgery. So, few things to finish off on how I do it. This is the last few minutes. This is not the important part of it. You can fix this with anything that you feel comfortable with. Arthroscopic is good, but remember that there are, and it's especially good for intra-articular pathology. So I tend to scope most of my patients, especially if I have clinical suspicion of any other labral capsular injury or a cuff injury. But usually it tends to be a diagnostic scope because 80 to 85% of the patients don't have anything else. I tend to do more often an open repair only because it allows me to address all the other anatomy, including the injury through the deltoid better. So if it's a grade 3, slightly unstable, then I can do it arthroscopically. But a big, massive injury, there has been complete disruption of the muscle, arthroscopically won't address the muscles themselves. So quite often it ends up being open or a combined procedure. Lots of different ways to fix it. And we know when there are hundreds of different ways to fix it, there isn't a good way to fix it, but we just need to recognize what we're trying to achieve. And then what we're trying to achieve is actually good stability to allow the ligaments or this to heal, or the synthetic or the artificial ligaments that we put in to kind of incorporate. So you want an implant that provides you with good stability. So hook plate is good, a dog bone is good, and lots of different ways to do it. And I use some of the Arthrex implants. So these are some of the techniques that I use for doing a chronic reconstruction, right? So Musaka technique, it allows me to put some allografts as well, through some bone tunnels, provide both some kind of biology as well as some stability. I have used hook plate quite a bit, right? So quite a few times when in acute cases, especially in high demand athletes with massive shoulders, I find that sometimes these small little buttons and so on are not strong enough. Again, you got to remember that you are relying on these small buttons to literally lift the whole arm up and keep it in place. It's not reducing the clavicle, you're reducing the arm to the clavicle. So in some big guys, something like a hook plate, although it is an instrument of the devil if you don't know how to use it properly, I tend to use it because I use it 3 months down with good stability. As I repair the muscles and the capsule, you take it out, and again, in a series of over 400 cases of just acute hook plates, no issues at all. All patients have very, very good stable shoulders as long as you respect the fact that you put in the hook plate and repaired the muscle, not cut the bone off and preserve the AC joint. So this is what a hook plate looks like, but you can have problems with the hook plate. So remember, you have to take them out and not allow them to contact sport before it's out. Again, this is another one way of doing it. So there's a lockdown ligament that I've used. I find is a very good augmentation, but often very difficult to position the clavicle anatomically with the right tension. So just skip through the last one. I'm just going to show you again another sample of how I do it using a dog bone. But what is important is that you guys choose an implant that is best for you in your practice, but try and achieve the concepts of providing good stability for acute injuries to allow for the injury to heal, or in the chronic cases, provide good stability so that the allografts or the autografts or the synthetic grafts that you put in have time to incorporate. So, lastly, in some cases, you may find that you've done your grafts and everything else, and you still have some anterior posterior instability. So sometimes I have put in screws with what's called an internal brace. I used to do them before the internal brace came out in cases that require it, but obviously the internal brace makes it very easy. Was actually 2 anchors with a bit of tape can provide an immense amount of anterior posterior instability control in cases where you have that anterior posterior instability after you've done your CC ligament augmentation. So lastly, rehab after fixation. Because you've achieved good, strong stability, the key is to get your patients going pretty quickly. So most of my patients go through an accelerated rehab program. They're allowed to do full hand, wrist, elbow, neck, scapula setting exercises immediately. At waist level, they're allowed to do full internal and external rotation. No limitations, no at all. But I do limit them to do certain things. You got to remember that the most torsional forces to the construct or to the ACJ comes in at the end range motions of the shoulder. So I tend to make sure that patients don't do hand behind back, cross arm adduction, or any elevation above 90 degrees for the first 6 weeks. And if I use a plate, I tend to remove it between 3 and 5 months. So key points are, it's a shoulder girdle scapular injury, not a clavicle injury. Grade less important than the clinical assessment. Rehab is very important, even in non-operative treatment. Address all the static and dynamic stabilizers, whether you're treating this conservatively or surgically. Acute injuries just need to provide stability surgically, but the chronic ones also require stability and some kind of augmentation of biology. With that, I thank you all for your time, and I'm happy to answer any questions you have.
Thank you, Dr. Noorani, for that fantastic presentation. Couple of questions. One is, do you repair the coracoclavicular ligament when you're treating an acute AC joint dislocation, or you try to reconstruct that? Do you address that part?
Yes. So having looked at quite a few of them, invariably what happens is the CC ligaments tear off as a periosteal sleeve, right? It's very difficult to repair it because there isn't an intra-substance repair. And we think if it was an intra-substance repair, it probably wouldn't heal either, right? Luckily, it tends to be a periosteal sleeve avulsion. So as long as the clavicle is in the right place, those things heal well. So I don't formally repair the CC ligaments and never have.
Do you think the use of a Bosworth screw doesn't make sense in today's practice?
So it may work in some people's hand. The Bosworth screws so I have a bias practice. I still see some Bosworth screws, a lot less than I used to. But my role was exclusively in fixing coracoids and fixing clavicle fractures with them, or osteolysis and so on. It is just too rigid an implant. And more importantly, it's a one-dimensional fixation from one point to another. And what is clear to me is that the AC joint dislocation is a three-dimensional problem. So even the original dog bones and all the fancy things that I was doing early in my career arthroscopically were two-point fixations. And they invariably have a high risk of failure. what you need to address is a three-dimensional thing. So the dog bone has multiple areas that has a wider footprint, but then you also address the AC ligaments, you address the muscles, you make sure you don't take the bone out. And quite frankly, right, in a lot of cases, the old traditional hook plate works really well, because yes, it goes under the acromion, but there's nothing like a hook plate or an AC joint to provide anterior, posterior, craniocaudal, as well as rotational stability. But not for everybody. If you use it, 2 operations are needed. And then basically you have to be a little bit careful they don't fall on it, because they can have cuff injuries, they can have acromion injuries, so you can't fix and forget that patient, right? They have to keep an eye on them. They need to know that needs to come out. But I'll be very honest with you, my precious high risk patients that are the pro athletes and so on invariably get some kind of hook plates, because I find that they have a much bigger injury and nothing like it provides stability. But obviously, if you have a young, slim female that is more cosmetically worried about the scar, hasn't got a significant injury, shoulder is 1/3 the weight of a rugby player's arm, yes, of course, something simple arthroscopically like a dog bone can do a job very, very well.
So you've done quite a few hook plates, is it?
Got a few words, sorry?
Hook plates. You've done a lot of hook plates.
So it is ACJ reconstruction is one of my most common operations. So there are lots. I see it a lot, right? So I'll probably end up doing. COVID is slightly different, but on a good year, I'll probably do 900 operations a year, and I would probably say, half of it is trauma, and within trauma, half of it is probably ACJ or clavicles. So yes, I've done lots of them, and lots of hook plates in particular.
And have you had any stress fractures on the medial end of the plate?
One fracture on the middle end of the plate in a slightly older gentleman in his 60s, perhaps with slightly osteoporotic bone, and with a acute injury falling off. He was a slightly old gentleman, but he liked his skateboarding. So he fell off a skateboard and he hurt his shoulder. That's the only case I know, because I know all of them, right? So now there are some cases where I see very rarely some osteolysis. Again, very, very rare. But what I've found is that when you use a hook plate, and if you get the tension right, i.e. get a fairly rigid fixation, and you repair the muscles, don't take the AC joint out, either you have a very stiff anatomical construct, then there is hardly any movement in the AC joint in the first 6 weeks, especially because you're limiting the range to waist level. So then you don't get anything at all. So invariably, most of my patients will not get stress fractures, but they'll also not get any hint of osteolysis because the fixation has been fixed so rigidly.
And you remove the plates at 3 months?
Yeah, so 3 to 6 months, but invariably my patients end up having some time between the end of 4th month and middle of the 5th month. So there is a slight convenience factor as well. So a few weeks here and there are there. The only exception to removing the hook plate slightly longer will be if there was a far lateral clavicle fracture, then I confirm that the bone is healed before I do it. Sometimes people take a little longer. When I take the hook plate out, I always have a augmentation device like artificial ligament and so on, just in case it is unstable. I have done so many of them, and not once I had to use it, because once you take the hook plate out, I stress it image wise and so on, and it is actually very, very stable. But I think it's stable only because you use the right hook plate size, and some people might feel that they want to protect the shoulder by using a larger hook or make it slightly looser. No, go for the tighter one, because that is actually better for stability and you get less problems with it. And if you repair everything else around, it all heals beautifully. I mean, the deltoid and trapezius looks absolutely anatomical with a nice Mason Allen repair when we take the hook plate out. So taking the hook plate out, AC joint is very stable, and the patients basically get back to normal activity pretty quickly after that. So it's a very small second operation.
And what is your approach for a type 1 and a type 2 rock wound?
Type 1 and type 2.
Yeah.
So a true type 1 and type 2. Somebody has ACJ pain, type 2. So I would put it down as, in my head, I would say a type 1 and type 2 is something that looks normal on X-ray, plus also is not unstable. Because sometimes, as you can appreciate, that it may look like a type 1, but when you feel it, it's actually wobbling everywhere, right? So a true type 1, which is stable on examination as well as looking normal on X-rays, I just rehab them. Few of them get some AC joint pain, and they get an injection. Very, very rarely, if they get more pain, they'll do an ACJ resection. If I am doing an ACJ resection or addressing a type 1 surgically, which is very, very rare, and chronically, if it's not been settled down, I find that it tends to happen is that either myself or somebody else has mistaken a type 1 or 2 for a proper type 1, 2, but actually was always an unstable injury. So type 1 or type 2, if it's unstable and has been not recognized as such, will more generally speaking, more give problems. So those are the ones I end up addressing late, especially when they refer to me as tertiary patients. But otherwise, a normal straightforward 1 and 2, I don't think most people are going to have problems with that. They heal quite nicely. So just
I think the message is like you need to have a 3-dimensional approach, and it is not the X-rays alone, isn't it?
X-rays will lead you in the wrong direction, and in this case, what you need to do is examine the patients.
Okay, thank you, Dr. Ali. I think there are no more questions. Thank you, Dr. Noorani, for spending your valuable time. This has been a fantastic session. A lot of insight into how to manage an AC joint injury. Thank you once again for being with us, and looking forward for more from your side. Thank you very much.
Pleasure. Thank you again.
Bye-bye.
Bye now. Have a good night.